Hi everyone, this is Dr. A, and I have your Clean Chem 1 lecture on toxicology, and within that we're going to look at drugs of abuse testing. Okay, so toxicology is the study of the adverse effects of chemicals on the body. And it could be all kinds of chemicals, so it could be drugs, but it could also be, pollutants and things you might be exposed to. There are approximately 24 toxins or drugs that account for about 80% of emergency department visits, and we're going to look at a lot of these. And so the uses for drug testing are a lot of times, like if a patient comes in and they're unconscious or there's something going on or there's any kind of suspicion that it might be have ingested some drugs, and we're just not sure what it is, and that would be a good call for drug testing. So anytime there's kind of altered consciousness, or somebody is unconscious, or we need to be able to, or they're not coherent, and we need to be able to determine maybe what's going on, that would call for drug testing. And there are certain amount of clinical information that's very useful to collect when we start looking at drug testing. So if it is possible to get this information, the time and date of exposure is really good. So of course, if the person is unconscious and nobody's witnessed taking anything, then this is some data you may not have. But sometimes people will come in and having intentionally taken a whole bunch of Tylenol or some other prescription drug, and they know they've taken it, they know what they've taken, and they can tell you usually what they've taken, and they know when they've taken it, how long ago. So if you have that, that's great information to have. But if not, at the very least, you need the time and date of the specimen, whether that specimen is blood or urine. And it's good, of course, the physician and nurses will collect the history and current medical condition information. So a toxidrome is a specific toxic syndrome that is created by a drug. And so it's like the effects that can be seen or measured or experienced. And so it would be like whether the exposure to a specific toxin, does it give you a person difficulty breathing? Does it sedate them? Does it cause nausea, vomiting, diarrhea? Does it cause a rash? Like what's going on? And so a toxidrome is a collection of signs and symptoms associated with that particular chemical. And there are databases for this that can be accessed to check if needed. So the routes of exposure are important in the influence of toxicity. So for example, on the skin, the ones you need to be concerned about are the fat-soluble chemicals, because fat-soluble chemicals can easily absorb through the skin, whereas water-soluble ones will be more likely to roll off and not soak through. Anything ingested, so anything that goes into the GI tract, can be absorbed, so just to be concerned there if something was ingested. In the lungs, it is the fastest route, so if a gas or something was inhaled, so the biggest problem is it can damage the mucosa, and that can cause a lot of inflammation and fluid accumulating in the lungs and a lot of difficulty breathing. Injection, usually those are drugs of abuse, so given intentionally through needles in the veins. They are very few toxins other than drugs of abuse that would be injectable. And then eyes would be a chemical splash or a gas, exposure to a gas, so in the lungs, like inhale, but also then it could come up into the eyes. And so in certain fields, that might be why you want to wear protective gear around the eye, but also protective gear around the mouth. So a little bit about the dose-response relationship, because this can be quite complicated, especially in toxicology. So a dose-response curve has to be set for each chemical or drug, and it's a comparison of the responses over a range of doses. And some of these may come from, cytology studies, animal studies, or known exposures and documentation of effects on known exposures. So in the dose response curve, the TD50, so toxic dose 50, It's the dose at which 50% of the population will experience a toxic adverse effect. So something that can be seen, measured, experienced, you can see what's going on. The LD50 is a lethal dose. 50 is a dose at which 50% of the population will experience a lethal dose, will die at that dose. So again, we're talking about toxic chemicals, etc. Just to give you an appreciation of all the different types of dose response curves, you can see there is a variety. We tend to assume it's this way because it's nice and pretty and linear, and we think, oh yeah, at the very low dose I have small effect, but the higher the dose, the more effect it's going to have. That's nice and pretty and clean, but no. So they could be here where there's a certain effect at any kind of dose, but then when you reach a certain threshold, it gets worse and worse and worse at the effect. Or there's a lot of chemicals out there that have this type of curve, meaning very low levels, so very low dose and really high dose have the most toxic effects, whereas kind of a middle of the road dose has the least amount of toxic effect. Anyway, so just give you an appreciation, like there are so many different types of dose response curve for different chemicals. You cannot assume that everything is nice and pretty and linear. And so there's a couple other terms you need to be aware of that you'll see used. So the NOEL is the no effect level, and the LOEL is the lowest effect level of a substance. And this is usually, it could be a prescription drug or something that is actually not really a toxin. So it could even be a vitamin and stuff. So, so this is showing like where there's no effect, where there's the lowest effect. So the lowest effect then would be, if it was something beneficial, would be the minimum dose that you would want to take to be able to start seeing an effect of something beneficial. And then when we really refer to toxins and drugs and things that are bad, is the no AL, so no adverse effect level, and the low AEL, so the lowest level at which there's an adverse effect. And so this is for toxins. So a certain level, no adverse effect, or the lowest level at which you start seeing an effect. Obviously, anything above that, the effect might be worse, depending again on the dose response curve. Poisons generally have no well-defined safe levels. They're really not supposed to be in our body. We're really not supposed to be exposed to them, and there's no safe level. So even though you may see sometimes on your like water reports, there's water quality for your tap water. There's like, oh, this is the level of this, and this. Well, some of those, you know, they may have deemed these levels safe, but are they really safe? Because there's, you know, some of these chemicals or toxins really have no business being in your body. And then some chemicals can exhibit bioaccumulation, and those that exhibit bioaccumulation don't really have a dose response curve, because they slowly, your body basically hides it away in your fat cells. So usually these are lipophilic chemicals, and the body has a hard time maybe detoxifying them or getting rid of them, and so what it does is it goes and stashes them in your fat cells. This, if you have bioaccumulation of chemicals in fat cells, it can make it really hard to lose weight because the body doesn't want to let go of the toxins. And a lot of the endocrine disruptors kind of fall into those. So all the plasticizers, BPA, etc., those guys can exhibit bioaccumulation and accumulate in someone's fat cells. Okay, so first little question for you guys to think of. So look up a chemical that's either an endocrine disruptor or exhibits bioaccumulation, and enter its name here, and where it can be found. Is it in the food supply, cosmetics, cleaning supplies, industrial manufacturing, etc.? So if you're at home and you want to do that, you can. Of course, you're in my class, you're going to do it. So there we go. A little exercise, a little practical application here. Okay, so let's move on and talk about acute and chronic toxicity. So pretty standard here. Acute toxicity occurs in a short amount of time. You either get one or multiple exposures in less than 24 hours and see adverse effects within 2 weeks, or within 14 days. Chronic toxicity is a lot harder to pick up on because it's like low-level exposure over long periods of time. And so, for example, chronic toxicity could come from drinking tap water that has low levels of certain chemicals, and you just day by day are just taking a little bit in, and so you get repeated continuous exposure. This can also happen with things such as pollutants in the air, etc. So, and it's hard because you're like not really aware of it. Okay, so next little application question. So if you live in a rural area near fields that are sprayed with chemicals every year during the growing season, what type of toxic chemical exposure would you be getting? Would it be acute or chronic? So think about that one for a second. Pretty easy application on that one. Okay, so next we're going to talk about specimen collection and handling for toxicology. So generally, blood or urine are the specimens of choice. And the container or the type of anticoagulant or preservative for the blood, you need to refer to the specific type of test that's done and what the reference lab requires. And the detection window is different whether you use blood or urine. So in blood is within hours, in urine is within days. So you're going to see a lot of toxicology testing is going to be done in urine. And there's other specimens that can be done for forensics and all that. So like hair, there's some toxins and things that can accumulate in hair. You can do 24-hour urines also. And then it's possible to do post-mortem samples on somebody that's passed away if, maybe it was an acute exposure. So for forensic testing, and in that you can use eye fluid, stomach fluid, or cerebrospinal fluid. So let's talk a little bit about adulteration. Sorry about that, couldn't say it. So adulteration is tampering with a sample or manipulating the urine specimen in a way to alter the test results. So these are basically people that are trying to fake out to beat the test because they have been taking a substance, they're not supposed to be taking it, and they want it to test negative. And so these adulterants can cause false negative results. A lot of them can be purchased over the internet. And you can test for adulteration by performing a creatinine test. So a test for dilution of the urine. So sometimes a person might try to put a little bit of urine in there and then maybe get a little bit of potty water or something to dilute it and hope that it reads negative. You can test your pH, specific gravity, and then it's possible to test for different adulteration substances that are sold over the internet. So here is what a typical test strip you can do to check for adulteration. Some of the ways around it is going to be a supervised collection. They are some places that do a lot of urine drug screens where they don't want adulteration, that will put dye in the potty water, shut off the water supply. The sink is not even in the same room, and in some places there's no door on the stall, so you have to supervise, watch them actually pee. And then you can also use temperature strips to make sure that urine is actually at body temperature. But some people can be quite slick. They can try to put the urine sample from somebody that they know is going to test negative, and they actually, tuck it away in a bag or something close to their body, get it nice and warm body temperature, and then they put it into the cup, to pass it as their own. So there's a lot of creative ways people use to get around, basically being able to get a negative drug screen when they really are positive or something. So again, one way, list a way a urine specimen for drug testing can be adulterated or modified. We do both screening and confirmation testing for drugs of abuse. So DAU is the abbreviation used for drugs of abuse testing. So the ones that are performed at hospitals and ERs and they are usually just a screening test, and they often include the statement that simply the results are to be used for medical purposes. They are just presumptive positives because there are things that can interfere and cause false positives in the screening test. If something needs to be confirmed for a reason or another, for legal purposes or whatever, they can do a GCMS, so gas chromatography, mass spectrometry confirmation test, and those are accurate. They're not subject to interferences like the screening test. Part of it's because the screening test use immunoassays. The osmolar gap can also be used. An elevated osmolar gap provides an indirect evidence of the presence of an abnormal solute. So the osmolar gap is the difference between the calculated osmolarity and the measured one. And so if there is a difference between the two, then it means that the test that actually measured the osmolarity detected some substances that are not being tested for in the normal chemistry panel. And then neonatal drug testing is often performed on a meconium sample. The meconium is the first bowel movement of the baby, and obviously that type of testing would be to detect whether the mom was using drugs. So a little bit on chain of custody. This is going to vary by hospital whether they actually even mess with chain of custody or not. But chain of custody is a process that has to be followed for evidence to be legally defensible, which means acceptable to courts and governmental agencies, which is why a lot of hospitals and stuff don't really want to mess with it because they don't want to be called into court to have to testify. But if you are in a facility or if you're working for an agency that does legal drug testing, then you have to abide with the chain of custody stuff. And so evidence collectors have to be a neutral party, so you can't be related or know the person that's giving the sample. You have to have no personal interest in the test results, right? And the whole chain of custody maintains control and accountability. So the document, actually what it looks like is the specimen is provided by, witness usually, but provided by the patient, and then the patient has to sign the form, and then the person that witnessed the collection has to sign the form, meaning they take custody of that specimen. And then they secure the specimen, and then the person that picks up in the courier that transports the specimen has to sign it. And then once it's delivered, if somebody receives it and processes it in, they have to sign the form. And then the person that actually opens the sample and does the testing and results out, if that's the same person, they have to sign it. Anyway, and so basically it documents every single person that has touched or handled the sample. So, the process can be scrutinized, if you will. A urine specimen that is given for legal purposes for drug testing is usually in a sealed container, tamper-evident container, so that it's given by the patient, and then the lid is put on it, and then the tamper seal is put in front of the patient. Usually the patient signs their initials on there. And then the sample and the chain of custody form stay together all the way through the entire process. So we're going to start with a little case before we get into specific toxins and toxicology. So Carl was found unconscious outside of his home on a snowy day. He was brought to the ER, and lots of labs were run, and his chemistries and ABGs were normal, except the ABG revealed a carboxyhemoglobin level of 20%. So that means he had carbon monoxide exposure. So what could have happened in the wintertime to give him carbon monoxide poisoning, and how is carbon monoxide poisoning lethal? Okay, so y'all think on that, and then when we get to it in the lesson, we will talk about it. So if you're going to be in my class, you're going to enter some answers to these two questions, but we're going to start with the conditions that are caused by pollutants. So pollutants are substances that contaminate air and water. They can cause short-term acute effects or long-term chronic effects. So some of the ones especially well known to cause long-term chronic effects are going to be smog. So for example, this is smog over LA. And there are other cities and stuff that have smog. This is pollution caused by all the cars, etc. Secondhand smoke can be really dangerous too. Again, chronic exposure long-term, especially to spouses and children of smokers. Cigarette smoke itself, again, really not good for your health at all. Radiation exposures, all of these things are types of pollutants that you can get chronic long-term exposure to. So let's look at specific toxic agents. We're going to start with methanol. Methanol is a wood alcohol, it can contaminate moonshine. So it's obviously not supposed to be in there. Moonshine is supposed to be just ethanol, right? But methanol could be mixed with ethanol and be hard to detect. And a toxic dose can be as little as 4 milliliters. That is not a lot. It can be detected using a serum osmolality test. Again, it would cause an increase in serum osmolality, and with a osmolar gap, you would see a difference between the measured would be much higher than the calculated. You can also do GCMS to detect methanol. So once methanol ingestion is confirmed, oddly enough, patients are given ethanol or formeprazole to inhibit the metabolism of methanol. So the deal with methanol is the metabolites are what's toxic. And the methanol and ethanol are eliminated in a zero order enzymatic reaction by the liver, meaning that there's only a certain amount of enzymes that can process it, and it processes it at a steady rate, and you can't, like, having more doesn't speed up the reaction or anything like that. So that's why it's zero order. And so the idea is to block the metabolism of methanol by saturating the enzymes with ethanol, and therefore allowing the body to simply pass methanol in the urine as methanol and not as its toxic metabolites, which are formic acid and lactic acid. But if the formic acid and lactic acid do accumulate, then sodium bicarb can be given to alleviate the metabolic acidosis. And in severe cases, you might have to do hemodialysis to clear the methanol and the formic acid. Next, we have isopropanol. That is a disinfectant rubbing alcohol. It's metabolized to acetone. Why would that be a problem? Well, basically, in case you didn't know, if you have somebody that's really addicted to alcohol and they don't have access to alcohol, and you leave them in an ER room and there's rubbing alcohol pads, they will start tearing the rubbing alcohol pads and sucking on the pads to get a certain amount of alcohol. And of course, it's isopropanol. It's not ethanol, but it kind of has some of the same effects. So it is metabolized to acetone, again, which has no business in your in the body either. 250 milliliters is lethal, so it's a much bigger lethal dose than methanol. And it can be detected by high-performance liquid chromatography and gas chromatography mass spectrometry. Ethylene glycol is antifreeze. The metabolites also are toxic. And one of the metabolites is oxalic acid, and it will crystallize as calcium oxalate crystals, which are shown right here. Very pretty crystals. They'll show up in the urine, but this can cause kidney failure, so this is really bad. So usually ethylene glycol antifreeze ingestion is done on purpose, or somebody could be trying to kill somebody by poisoning them. It's used to, I think they've changed it. It used to be like really sweet, so you can like hide it in sodas and stuff. But most of the time, this is intentional ingestion for suicide attempts. So ethylene glycol ingestion will lead to a profound acidosis, and the goal of the therapy in ethylene glycol is to try to treat the patient before the acidosis develops. And a toxic dose is 100 grams, which is not that much, really. Next, we have formaldehyde. It is a carcinogen. It is of concern because it is used extensively in labs and in physician offices that collect tissue samples to preserve these tissue samples. And anybody that handles formaldehyde, there's mandatory testing that requires to ensure that the formaldehyde exposure levels do not exceed acceptable levels. And so the staff has to have to wear a formaldehyde exposure badge that detects the amount that they are exposed to, and then they're sent out every year to an outside agency for analysis, and all of that stuff is tracked. Benzene, it comes from crude oil. Processing of crude oil is found in car exhaust. It is a carcinogen, and again, low levels can cause toxicity, so that could be in smog, CDs, and all that if you breathe that a lot. And xylene is used in petroleum refining, so again, same thing, solvent. Car pollution has xylene, but paint fumes also has xylene. Next, we have carbon monoxide. So this was the Carl's case. Carl got exposed to carbon monoxide. So likely what happened is not so much that he would have a fire, although he can get carbon monoxide exposure in house fires and stuff through the exposure of the smoke. But often if there is gas furnace or something and the pallet light goes out or something and the gas is going into the house but it's not lit, it's not being burnt, then you can have an accumulation of carbon monoxide and carbon monoxide poisoning. It is a silent killer because you can't really smell it, detect it. It induces hypoxia, so it drives oxygen concentration way down, and it does that because carbon monoxide has a greater affinity for hemoglobin and oxygen, so it basically binds on hemoglobin and it won't let oxygen bind, and it does never unbind. And so every cell that's taken up with carbon monoxide molecules cannot carry oxygen in your red cells. And so we can test for carbon monoxide and hemoglobin, so carboxyhemoglobin, and other hemoglobin variants using certain blood gas analyzers that have the co-oximeters that do the blood gas variant. So most ABGs do test for this. Cyanide exposure can occur through pest control, so it's in like rat poisons and stuff. Organophosphate exposure can occur around insecticides, and radon will be around in the home, especially newer homes or homes where they have like manufactured furniture that's pretty recent that's like off-gassing some of this stuff. Household products, we have bleach. So first of all, you should handle bleach with gloves. It can absorb through your skin, etc. But if it is mixed with ammonia, it can make chlorine gas, and just ammonia can be found in window cleaners. So some cleaners have ammonia, some cleaners have bleach, and chlorine gas is deadly. And so you should never mix different cleaners. You need to watch which cleaners you spray on what, and if you layer them, which you shouldn't do. And so, again, you can get either skin or inhalation exposure around bleach, and you have to be very careful. Paint, so older paints contain lead, paints that were made prior to 1960, so that could be a concern, especially if children are like chewing on something that's an old toy, wood toy or something, or paint chips, so they're picking up paint chips and chewing on them from an old painted house, or something like that. So, bug repellents contain DEET, it's a neurotoxic, and ammonia is contained in window cleaners. So all of these are things that you definitely want to limit your exposure to. So this is a little activity for my class to match up some of these. So now we're going to move to the toxic metals. So aluminum is found in certain antacids and in deodorants. It has been linked to Alzheimer's and breast cancer. Aluminum has zero use in your body, like you have no use for aluminum. It's a toxic metal. Lead is another toxic metal. It interferes with the synthesis of heme from porphyrin, so messes with making red cells. And the anemia caused by the lack of heme is frequently observed in lead toxicity. Young children are particularly prone to lead toxicity, and in young children, it can lower IQ points, cause brain damage, cause all kinds of problems. It is usually detected by atomic absorption spectroscopy and mass spectrometry. The contamination of drinking water with lead has been a concern. That was the Flint, Michigan debacle and disaster, and this can happen if excess chlorine is used to decontaminate the water. So if the water is contaminated, they use a lot of extra chlorine, and there are lead pipes in the system. The chlorine will cause the lead to leach from the pipes and get into the water, and then children can be exposed to it that way, and so can adults. But it profoundly affects children, their attention span, their IQ, and their brain development. Chromium. So chromium has a toxic and an essential form. So hexavalent chromium, or chromium-6, is the toxic form, and it's used in factories, so it can contaminate water and soil around factories. And trivalent chromium, or chromium-3, is essential, and it's needed to work with insulin for blood sugar control, etc. Next, we have arsenic. So arsenic exists in both toxic and non-toxic forms. It's still found in some insecticides. It can be ingested through contaminated water, and because it's, again, some of the stuff can be sprayed on fields, and so it can contaminate the water and water supply. Again, it can get acute or chronic exposure. Acute would be if you're around what's the insecticide actually being sprayed, or it's a big dose that's given maybe as somebody's trying to kill somebody else. Chronic exposure, again, would be more like that low-level exposure through contaminated water. Usually you want to do hair and nail analysis for arsenic because it has an affinity for keratin. Keratin is the protein in hair that makes your hair strong. Beryllium is used in many commercial uses, and it can cause lung inflammation, berylliosis. Cadmium is used in electroplating, and it's found in tobacco, and it is toxic to the kidneys. Mercury is used in the industry and in dental fillings. So the silver dental fillings, older dental fillings, they can accumulate in fishes and shellfishes, and mercury can cause protein denaturation. So there's a lot of this is one of the heavy metal toxicity that can go undetected for a long time and cause all kinds of health problems. So most clinical labs don't perform metal testing. Specimens are usually sent to reference labs for toxic metal testing. Again, a little activity. All right, so now we're going to talk about drugs of abuse. So many drugs of abuse have addictive potential, which is why people abuse them. And tolerance is the body's reaction to the drug, where the person needs the drug to function even normally. And so that, of course, causes dependence on the drug. Drugs of abuse can be recreational drugs or pharmaceutical drugs. Designer drugs are usually modified recreational or pharmaceutical drugs and can be somewhat harder to detect because they're not quite the same. Testing is generally done screening by immunoassay and then confirmation by gas chromatography mass spectrometry. And if the test is being performed just for medical reasons, usually we don't do confirmation, we just do the immunoassay screen. And so basically the screens will detect the presence of the drug above the limit of toxicity. And so that basically the idea is the physician just needs to know what this person has taken so that they can treat them appropriately. So first we'll start with amphetamines. They are a class of psychostimulants. They increase wakefulness and focus and decrease fatigue and appetite. Users can develop tolerance. They work by boosting norepinephrine, dopamine, and serotonin, which then has these effects again of wakefulness and focus in the central nervous system, so your brain and spinal cord, and in the peripheral nervous system. The short-term risk of amphetamine use are going to be high blood pressure and heart attacks. The long-term use risk is going to be necrosis of the heart, cardiomyopathy, and psychosis. MDMA is also known as ecstasy. It is an amphetamine that is often used in nightclubs, and it increases serotonin levels. And the short-term risk of MDMA is going to be hyperthermia. It messes with temperature control. So the amphetamines are part of most urine drug tests that are performed in the hospitals and the drug screens. The typical cutoff is 1,000 nanograms per ml. This is considered a level of abuse. Some assays will detect only amphetamines, and some will detect and differentiate between amphetamines and methamphetamines. The screens are usually performed for medical reasons and are not sent out for confirmation. If the amount of amphetamine from MDMA is greater than 1,000 nanograms per ml, then it will be detected on an amphetamine screen. However, many physicians do request specific MDMA testing, and that would require gas chromatography mass spectrometry testing. Next is cocaine. So it is a powerfully addictive stimulant. It is used as a local anesthetic and as a vasoconstrictor. It is similar to amphetamine in its effects, but the effects last a much shorter amount of time. It blocks dopamine and norepinephrine reuptake, so there's some similarities there. So as in that would cause it to increase dopamine and norepinephrine. So that's how it's similar to amphetamines. And the risks are going to be acute cardiovascular and cerebrovascular emergencies, which basically means it can give you a heart attack or a stroke. The cocaine cutoff is set at about 300 nanograms per mil in a urine drug screen. Very rarely is confirmation requested for hospitalized patients. Usually, if you know that's what they're taking, that's just all you need to know. It does pass through the placenta, so in cases where it is suspected that a pregnant mother was abusing cocaine, the testing will be performed on the newborn. If the meconium is produced, so meconium is that first bowel movement, so that first bowel movement will be basically from the amniotic fluid, etc. And that is the specimen of choice. If there's no meconium or it's not possible to collect it, sometimes they pass it as they're being born, then a urine specimen can be obtained from the baby and tested, obviously, to check to see. And then in some states, I know in our state, then the baby can be taken away from the mom and be awarded to the state or to family of the mom if the baby is positive for cocaine. And certain other drugs too, like amphetamines, etc. Marijuana, so it is the most commonly abused illicit drug, although now it's legal in a lot of states, so it's not really illicit in a lot of places. Hashish is more potent than marijuana. The effects of marijuana are attributed to tetrahydrocannabidiol, or THC. And this causes distorted perceptions, impaired coordination, and problems with memory. It mimics the endocannabinoid system that is in our body. So we do have endogenous cannabinoids, so substances that are related or similar to THC and CBD. And again, actually with all of these drugs, they work because we have receptors for them, but the receptors were not designed to be a receptor for that specific drug. They're usually a receptor for an endogenous substance to have an equivalent effect. Marijuana is habit forming. It can lead to schizophrenia, especially in young men. And medical marijuana is often used for nausea relief, for analgesia, so pain control, glaucoma, even PTSD and other uses. But it's worth mentioning too that CBD does not have the habit-forming effects and has a lot of the beneficial effects, and it can be sold now in the U.S., so CBD might be a better alternative than THC. The cutoff for detection in the immunoassays is about 50 nanograms per mil. Marijuana and its metabolites remain in the system for several days. Chronic users, it can remain detectable for a month or longer. K2 is a synthetic marijuana, and so if you've ever heard of a case of somebody dying from marijuana overdose, this is going to be probably a K2 synthetic marijuana case. This thing is dangerous. And yes, my husband has seen some of these cases. And so I just want to share this. I really love Dr. Daniel Amen. He has done SPECT imaging, and he has collected a lot of the images on what normal healthy brain scans look like. So this is good blood flow to the brain, and then what drugs and other things damage, how it damages the brain and the blood flow. So this one, the 4 years of marijuana use, person is 17, you can already see the damage in the brain. 4 years of smoking at 22, you can already see damage in the brain. Blood flow to the brain has been compromised. 38, with 6 years of opiates, we have damage in the brain. 4 years of cocaine at 32. Again, lots of damage here. 10 years of alcohol at age 45. And 3 years of meth at age 28. You can see literally poking holes in the brain. Lack of blood flow in all the areas that have holes. So, again, another reason, the biggest reason to not do drugs is it damages your brain and therefore your mental health. PCP, also known as angel dust, is a dissociative drug. It causes severe psychological disturbances. I've seen this laced into THC, into marijuana. It is hallucinogenic and neurotoxic. The effects vary and are very unpredictable. Chronic effect of PCP use is memory loss. It can be detected by immunoassay. The cutoff is 25 nanograms per ml. Next is LSD. Is a potent psychedelic hallucinogen. It produces perceptual distortions. Detection is challenging due to the short window of detection. It is not commonly part of a routine drug test. If testing is requested, they usually have to be sent to a reference lab. Codeine and morphine. So these are opiates. Opiates are used to control pain. Codeine can be used to control and reduce coughs. Morphine is highly addictive. There are semi-synthetic derivatives of morphines, and those include heroin, oxycodone, and oxymorphone. Heroin is converted to morphine after crossing the blood-brain barrier, and morphine and heroin can produce withdrawal symptoms, again, because they are highly, highly addictive. To screen for opiates, generally the general opiates cutoff is 300 nanograms per ml, but then if specific testing is requested, then each specific opiate has a different cutoff. So heroin has a cutoff of 380 nanograms per ml before the immunoassay will be positive. The other ones have varying cutoffs. For example, hydrocodone is 650, hydromorphone is 1400, oxycodone is 10,500. So the manufacturer of the assay will provide the cutoffs if those are needed for information for the physician. Methadone is a synthetic analog of morphine and heroin. It is used as an analgesic, so to control pain, and to treat opioid dependency. So you can use methadone to get them off of morphine, basically. And it reduces opiate cravings and withdrawal symptoms. It is more active and toxic, however, than morphine, and patients can develop tolerance also using methadone. And methadone, of course, then is often part of the 10-panel drug screen performed because patients are put on it to get them off of the opiates. Your barbiturates are central nervous system depressants. They are mild sedatives, and they are anxiolytic, meaning they can control anxiety. Some of the examples of barbiturates are amobarbital or amytal, secobarbital, which is seconal, and butabarbital, which is butasol, and pentobarbital, which is nembutal, and there is a bunch more. They have largely been replaced by benzodiazepines. Overdoses can cause respiratory arrest, because you forget to breathe. They are addictive. They enhance GABA signaling, and patients can develop tolerance to these also. So barbiturates are part of most urine drug screens. The cutoff is about 300 nanograms per ml. However, it does not provide information as to what type of barbiturate has been used, so it just tests for the whole category of drugs. And this information could be important because the treatment options are different for specific barbiturates. So this hopefully is information you can get from the patient, but if not, then if you have to actually test for it to detect what they have taken, you need to use gas chromatography and mass spectrometry. And specific barbiturates, such as phenobarbital, though, can be performed on many chemistry or immunoassay analyzers. Benzodiazepines are sedative hypnotics. They're anxiolytics, so again, can control anxiety. They're also anticonvulsants, so they can control seizures, and there are muscle relaxants. This is Xanax and Valium. Those are two big names of them. There are more than that. They are less toxic than barbiturates, which is why they're being used more than barbiturates now. If they are combined with other central nervous system depressants, the toxicity increases. So these are some that you would not want to pair with alcohol. They can cause the development of tolerance and dependence on these benzodiazepines. The cutoff for the urine benzo is about 300 nanograms per ml. And again, the screen can identify only that benzodiazepines are present, cannot tell you which one. Again, it's just like barbiturates, it tests for the broad category of the drugs, and you'd have to use GCMS to get the specific drug identification if that is needed. A lot of times, if the patient has a prescription for it, that's usually the source of it. And so Again, this little question is, which one of these is not commonly tested for as part of a medical drug screen? Which one did we say was not commonly done? If you not sure, just go back. Another little check knowledge question. Which one of these is used in the treatment of opiate addiction? One of these is in there. Okay. Moving on to ethanol, it is widely used and abused. This is just alcohol. Run-of-the-mill alcohol, wine, beer, liquor, whatever can be bought at party stores, etc. They act as a depressant. They're intoxicants and psychoactive substances at levels greater than 400 milligrams per deciliter in the blood. You can see coma and death, so they can be deadly. It has a synergistic depressant effect when combined with other depressants, such as the benzodiazepines, Xanax, and other things. So it combines, it deepens the effect. And this is where you can see patients that could have taken some benzo, some Xanax with some wine and taken a little too much of both, and having some problems. Their level of consciousness is way down, and they're not breathing right and all that, and it may have just completely not intended to have that effect, but when combined, again, alcohol and other central nervous system depressants can have sometimes a lethal effect. Fetal alcohol disorder is a big concern for pregnant women that still drink. You can do legal alcohol testing, especially if somebody has been driving impaired. Blood or serum alcohol testing is very common. Most clinical chemistry analyzers have ethanol capabilities, and this is, again, you want to see if they're getting close to this toxic dose or where are they. Most assays are enzymatic and measure down to approximately 10 milligrams per DL, meaning that you can't say it's zero. So if somebody had not been ingesting ethanol, or it had been a long time and it had completely cleared their body, then you will essentially, if the levels are below 10 milligrams per deciliter, they would just be reported as less than 10 milligrams per deciliter. Hydromorphone is also known as Dilaudid. It is a morphine derivative, an analgesic, so used to control pain. It causes sedation, euphoria, and respiratory depression. So again, these guys can also forget to breathe if you take too much of that. The effects are increasing again with combined with other central nervous system depressants, such as alcohol or other opiates. And specific testing is required to detect Dilaudid or hydromorphone. Hydrocodone and oxycodone are synthetic opioids. They're also analgesics, again, to control pain. They are commonly used recreationally. They cause sedation, euphoria, and respiratory depression too. The testing for oxycodone is available in a urine drug screen. There are various limits available. Many laboratories use cutoff of about 100 nanograms per ml. Oxycodone is often used in pain management, and urine tests are performed on patients taking it to ensure compliance, because these little guys can fetch a lot of money on the black market. So some patients might fake pain to get them to sell them to make money, and so pain clinics usually don't like that, and so they test the patients to make sure that they actually are in compliance with their pain management protocol. The cutoff for this testing is usually lower and usually performed by GCMS. So for hydrocodone and oxycodone here. And then lastly, unfortunately, drugs used for sexual assault. They are usually fast-acting, colorless, and tasteless. So for that, one should never accept drinks from strangers, things that you have not seen poured. It should never leave your drink unattended, etc., etc. And if you ever see somebody put something in somebody else's drink, you should really tell them right away. These drugs lead to impaired judgment, reduced inhibition, sedation, loss of coordination, and amnesia. Forget what's happened to them. There are several types. There are some benzodiazepines like rohypnol, which is flunitrazepam. There are chloral hydrates. There are sedative hypnotics like Ambien, GHB, PCP, And benzodiazepines and PCP are going to be the only two that will be detected in a routine drug screen. The other ones like GHB, the chlorohydrates, and the ambient stuff, sedative hypnotics, may require specific testing that is only available in a reference lab. So, there you have it. All right, so if you have any questions, you can drop them below. I do appreciate your attention. And last little question check here for those in my class. If the patient is very agitated, which one of these would you suspect? Hint, hint. Most of them are downers, only one is an upper. So you probably would suspect the upper, right? And one more question here. If a patient is unconscious, which one may you suspect? Again, only one of those is upper. Only one of those is a downer. All the others are uppers. Yeah, sorry. Uppers and downers make a difference. Which one would you suspect here? There you go. Sorry about that. Kind of goofy at the end here. It's the end of the semester. What can I say? Anyway, if you have any questions, drop them below in comments. I thank you.